Hello and welcome to this week's episode of Two Southern Nurses, Doses of Wit and Wisdom, brought to you by Plain Speak Productions. Here are your hosts, Donna Parker and Tammy Clark.
Hi, thank you for stopping in. I'm Donna Parker. This is Tammy Clark, and we are back to present another episode of Two Southern Nurses, Doses of Wit and Wisdom. Pharmacy is another one that goes, it's a big
part of that team. It's part of the nursing team. We got to have them. Yeah. They got to have us, or we don't have jobs, either one of us.
Yeah.
So, yeah.
And, with that, of course, we want to talk about medication side effects, right? Because how important is it that we are documenting when patients are having side effects? Otherwise, we're going to keep giving them their stuff.
That's true.
Until something bad happens. Yeah. Maybe they get so dizzy or the blood pressure's dropping out and it's too high to dose or something.
Yep.
And drop that blood pressure and then they're falling in therapy. Well, is it because they're weak or because they're over-medicated?
Right. Yeah, or orthostatic hypotension.
Yeah.
Which is every nursing student's tattoo, right?
Absolutely.
Because that is just the most common that we see amongst polypharmacy population of the elderly. They take all these medications and the main side effect is orthostatic hypotension. They stand up, they pass out.
Yeah.
It's a big safety thing too. At home, it's a safety thing, but,
so what do we talk about with that? Let's dangle. You got to sit on the side of the bed.
Slowly sit up. Wait 10
minutes.
Yeah. Dangle 10 minutes.
If you have a bed that the head of the bed raised,
yes,
raise the head of the bed. Please do not pull on these folks to sit them up and swing them around to the side of the bed.
You're going to pull their stock.
You're going to bruise them, pull something out, do a skin tear. Something is going to happen.
Don't pull on them.
Oh, geez. Ever pull on them. But if you don't have a bed that raises up, it's easier to put them on their side and you kind of drop their feet over and help them come up that way. You're not pulling on their joints.
Right.
And we'll talk about some of the dangling and those position things. Of course, in the videos.
Well, and truly, even at home care, you could teach the families these kind of things too. Yeah. Do a draw sheet.
Yeah.
You got flat sheets at home. Fold it in half when you're making that bed, right?
Yeah.
And put that sheet underneath them. So to sit them up, you could turn them on their side, or, to set them up like that. You could, if you're
in a twin bed.
Yeah, that's true.
Because if you're in a big bed, you're not going to be able to.
No, you have to have one on each side to just pull the sheet, and that would pull them up. Okay.
Right. But most folks don't have two people at home to help them.
They usually don't. And they may not have the strength, even in a twin bed, to pull them up.
Right.
But, they need to know that sometimes. Now, there used to be someone come up with the transfer sheets. Wasn't they made out of vinyl so they slid? And you could
we've always used the
pull them up.
Sheet.
Really?
Yeah.
And in rehab we had they were called transfer sheets, and they were made out of vinyl material, so they were slippery. So when you went to you turn them on their side, they're laying on the side, you could pull both sides and bring them to a sitting position.
Yeah.
Transferring them from one bed to a stretcher, or from the bed to a toilet seat.
Yeah.
It was like they slid better on a slide board. They slid better against the sheets, against their pajamas, or, so. It was
because friction becomes another problem, right?
Then
we end up with
the main issue.
Yeah, we end up with friction.
Yeah.
And then we're going to have a skin tear. We're going to have some kind of an issue.
Yeah.
Another thing that we got, especially as we get older, our skin is loose. It gets thin. We lose weight. We got wrinkles and rolls and whatever, and and then we got a problem.
They say at 65 years of age is when we lose that extra cushion between our subcutaneous layer and our skin. So that's why when you're taking care of someone older than that, you see those blue veins, and it just looks like a really thin layer of skin over top, everything underneath it.
All the padding is gone.
Oh, absolutely. You start an IV or you stick for a phlebotomy or something, And oh my gosh, what? You got purple.
Yeah.
Because they bleed easier because those vessels are, they don't have
Fragile.
that, they're not in that cushioning
Because they
again,
don't have,
right?
and they don't have the elasticity that
Nope,
they had.
nope.
So
Yeah, so the vessels aren't protected anymore
That's
either
right.
with that subcutaneous level gone. So then they bleed underneath the skin and they get the purple.
yeah, you end up with this big old
Yeah,
hematoma.
absolutely, you do.
And then
You
your
can't
heart
stick 'em.
breaks.
Yeah.
And they're upset, and the family's upset, and you're
Family's
upset because
upset.
you don't want to do that to nobody.
Mhm.
And that's when size matters on your
Absolutely.
IV. Do you need a butterfly for this one? Is it
That's
something that you
absolutely
can
true.
administer? Maybe you can't
The
draw blood from
pediatric
them,
tube. Yeah,
but you gotta be individualized.
Yeah.
Again, know your population, know
yes.
where they are. Maybe you have a 60 or 70-year-old person, chronological age,
Mhm.
but cognitive age, 20
Right.
or 12.
That's true.
So you've got to adapt, and you've got to do things and encourage them in something that they can relate to.
That's
right.
Mhm.
So
You have to meet them at their level, right?
Sure.
As
meet them where they are.
where
Dementia.
we got that shirt, right?
Yeah.
But not with just dementia.
Yeah.
With whatever the issue is that has reverted them back, we just have to assess and know how to speak to them on their level.
Yeah.
Even as a pediatric nurse, what do? We squat down to their level, or we sit
Yeah.
in a chair at their I with kids.
Yeah.
So
Yeah.
same thing mentally, communication, meet them at their level.
Yeah.
For sure. That's just part of being a nurse.
And don't stand over them. I mean, when you're talking to somebody, you don't want to be stood over and
They
intimidated.
feel, yeah, they feel threatened
Mhm.
by you standing over them.
Yeah. If you don't have a chair, squat down if you
Yeah.
can.
Mm-hmm. So that's all that body language.
Body language.
Well, what if they can't speak, but you can read body language?
Get communication
Gestures.
boards. We're working on communication boards. Again, pictures.
Yeah.
Maybe they're all uptight. Are you hot? Are you hurting? Are you got to go to the bathroom? Are you hungry? You got a wedgie? Like, what is the problem?
What's the problem?
Let's figure it out.
Yeah.
And they can point. Or if you have access to, or you get a speech therapist to prescribe,
That's true.
they make those that you can look at a letter and it'll spell it out, or you'll look at a word, or
Yeah,
the adaptive technology is amazing.
that's true.
So we need to know as nurses, hey, this communication board's not working. Let's can we do a speech therapy referral? Get an order for a speech therapy referral. Hey, Mr. So-and-so, I think you would do great if we could have some assistive technology to communicate. He's struggling with communication.
Yes.
Man, you're going to come in there with that. Once he figures how to use it, his self-esteem is going to go up. His
Yes.
participation, he's going to turn around. All because, hey, I
Yeah.
can't do it, but I know somebody that can. As nurses, we wear a whole bunch of hats. And that's one of the things is knowing when we need help from another.
Yeah,
Specialty.
department. That's
Yeah.
true. That's
Yeah.
true. Yeah. I need to call speech. I need to call occupational therapy, physical therapy, the neuropsychologist.
Yeah.
I mean, or the neuropsychologist. We always had neuropsych in the building. So they tried to cover every area.
Yeah.
Of
Yeah.
course. So a lot of people, if you saw some issues, absolutely, as a nurse,
Use our resources.
you call and say, hey, we can evaluate them. You can write an evaluation, tell the doc, and say, hey, this and this and this.
Yeah.
I feel like they would benefit from a neuropsych eval.
Yeah.
So
Yeah. Communication. All the facilities I worked at had a doctor communication board.
oh really?
Oh, yeah. The date, the time you put it on there, what the issue was, the
okay. I know what
patient.
you're talking about.
And then
yeah.
when the nurse
Yeah.
practitioner, whoever came around and did rounds,
They looked.
you already had
Yeah,
your list
look.
of things
Yeah.
there
Mhm.
in case you weren't at the desk when he got
That's it.
there.
Mhm.
And then they'll come look you up. Hey, I saw you put so-and-so on the board. Thanks for putting the labs on there with it. Yeah, I agree, or I don't. And then
Right.
I'm going to educate you as to what we're going to be doing.
Mhm.
And then you're going to carry out those orders and update everybody. And we're a step closer to getting that patient where they need to be.
That
Emergency room nurses we call that organized chaos. Either you love the ER or you don't.
Right.
And those
And
are a
you know
special set of
quickly.
nurses. Yes.
Quickly.
That are there to receive you when you are at some kind of a traumatic point. Please don't be disrespectful to the ER staff. They do not, they're not there to harm anybody. They're not to insult anybody.
No.
Communicate with them. Let them know in an organized, calm, hopefully calm manner what works or doesn't work for your loved one.
Yeah.
Hey, we've tried this in the past, or I think this is going on, but we don't need no ugly words. We don't need no threats.
No.
None of those things. Please keep that in mind.
Yeah.
Hospice and palliative care, of course, those are fantastic services. People.
World Hospice and Palliative Care
Yeah.
Day on October the 13th. That's, I mean, and if you think about it, yeah, it's worldwide.
Yeah.
But that's amazing that hospice has
The
become,
recognition.
yeah.
Back
It's
in the
needed.
day, the big stigma about hospice, almost like there is about mental health.
Yeah.
People think that you only go to hospice to die. Okay. Hospice is so much more. Much more. Talk about communication and support and empathy, sympathy, pain control, quality of life. Those are all things that hospice
Yes.
can help you and your loved ones with. It's a journey. It is, it's not necessarily a short journey anymore.
No.
Folks go into hospice and they can be in hospice for an extended period of
They
time.
sure can.
Depending on their response to therapy, depending on all these things, because they're all individuals. So please, if that comes up with your providers, your care team, your family's care team, and they want to talk about palliative care, hey, we need quality and we need comfort at this point of our journey through this world, then be open to it and sit and talk with somebody. And with that, donor services.
Oh, yeah.
Right. So I don't know if that falls somewhere on down the line on our papers or, but I know when I worked in burn and trauma and all the ICUs, donor services was a big part.
It's a big part.
And talking with the families is a most difficult conversation to have.
Yes.
When they're already
just lost them. Yes.
Right.
Yeah.
Right. And so those are services that you need to understand that you're going to, those folks don't need those parts where they're going. Okay.
Yeah.
And we can help so many other people just from one donor body. Even with the burn unit, just having that cadaver skin to carry those folks over until their wounds, till their burns.
Good grafts.
It's life-saving.
Yep.
And what if we didn't have those? We had to grow their skin, get you sent off little postage stamp size, and it goes to a lab and it takes a long time.
Yeah.
And there's things that can happen.
And in the meantime, they get an infection.
That's right.
And then their life's at risk.
That's right.
So.
And comfort. And it's if you scald your finger, how hurtful is that?
Yeah.
And then you're talking second, third degree burns
all over.
Wherever.
They can't move.
Excruciating.
Yeah.
Physically, mentally, emotionally.
Yeah.
Those families went through it.
Can't imagine. And the patients, I can imagine.
Yeah.
The pain.
Yeah. Yeah. A lot of sedation, a lot of medication.
Yeah.
A lot of psych services.
Thank God we have that for that area of care because would you not? I mean, truly, I think if we didn't have that, dying of pain would be a real thing.
It would be. It would be.
Because that would be the area. Because they have more pain.
Yeah. Suicide would be much higher.
Yeah.
Because there comes a point where you can't drown it out. You can't deal with it anymore.
Yeah. Living with pain is not easy.
Yeah.
I mean, think about if you ever had a stomach ache and it just would not stop and kept on and on and on. It usually goes away, right? Or you take a little something, it goes away. Can you imagine it never stopping? Yeah. And every day you get up and have the same thing.
And know that it's not going
to go away. There's nothing I can do that's going to go away.
You don't want to eat. You don't want to drink.
No.
You got to eat and you got to drink something.
No, you get to the point where you don't leave the house.
Yeah.
It's too much to get up and get dressed. You can't do things like that anymore.
Yeah.
So it's a real thing in many conditions. I mean, that's an acute condition, and I can't imagine, but
acute on chronic sometimes.
oh,
Sometimes,
yeah, absolutely.
because I'll tell you,
It becomes chronic.
my folks with workers' comp that have nerve injury, they said that they say over and over, there's nothing like a broken bone, a strain,
It's
a
not.
pull, a cut, a dislocation. Nerve pain is its own beast,
It is.
and it is debilitating for some of these folks.
Yep.
Started out everything good, you end up with an injury, and here you are. This is what you're looking at.
We don't address nerve pain, somatic pain, non-somatic pain, visceral pain. We got different kinds of pain, but nerve pain, it is a beast all of itself. People say, I've got pain. Well, when they say I've got pain, it's usually, they pulled a muscle, or they got something throbbing, or, they got a tear in their meniscus or something. Pressure, a stabbing pain. Nerve pain is completely different. It's burning.
Yeah.
It's tingling. It's numbness.
It radiates.
It radiates from one area to the other.
Yeah.
And truly, I don't think we have a handle on nerve pain, because there's a fine line between sedating them and suppressing respirations with narcotics for pain versus taking away that pain, because I don't think it ever takes away.
Yeah.
You have to treat it with different things.
I know that what I've learned just in the workers' comp world is it is very slow to regenerate.
Yes,
very, very slow.
it is.
Healing process,
Yes.
years. It could take years
Yes,
for the nerves to
and
heal.
statistics tell us that people who are in a state of pain heal at a slower rate.
Right.
So nerves heal slowest thing that heal in the body anyway, because they tell you if you have damaged nerves, they could heal up to 3 years.
Yes. Yeah.
Can you imagine?
Yes.
I mean,
The medication is sedating,
it's
so if you're
suppresses
working,
respiration.
you are not going to be able to take that during the day.
No,
Because you're going to be sleeping on your desk or drooling or something.
that's right.
You're not going to be able to do it. So you're in pain all day, and you try to get some rest at night and take it.
Mm-hmm.
And either you're so loopy in the morning when you get up, or it just doesn't. It's just not. You just don't get a good
You
quality.
have delayed sedation a lot of times with those anti-seizure, antidepressive drugs, and that's what they're using now. A lot of times with nerve pain. Yes,
Narcan.
yes, Narcan, gabapentin, which is Narcan, Lyrica, which is pregabalin, Cymbalta. They use a lot of the antidepressants, anti-anxieties, also for pain now.
Yeah.
They say it's helping with nerve pain.
Right. So communication again. If you're talking to your patient and he's like, my leg is on fire,
Right,
it is
right.
shooting. It is. You're like, he's only on a muscle relaxer.
There
That
you
ain't
go.
gonna do diddly
Right.
for this nerve pain,
Right.
So then your nursing, your critical thinking skills come in, and you say, okay, I need to call the nurse practitioner or the doc and say, we've got some nerve pain going on.
Absolutely.
So then we're going to get an order for something. Either it's going to be testing for a nerve conduction study, somebody's going to come in and do something on site, we're going to get an order to see how they tolerate the nerve medication. Some kind of process is going to start because he communicated that we're not, his medication list, he could eat those pain pills all day long, and they're not going to touch his nerve pain.
And that is the responsibility of the nurse, because now we have pre and post pain assessments where we have to ask, what type of pain is it? Yes, on a scale from 0 to 10. Yes, is it continuous? Is it intermittent? Is it stabbing? Is it burning? Is it tingling? Is it not?
What causes the pain? What alleviates the pain?
Absolutely.
Those things.
And after we give you medication, when does the pain improve? After 30 minutes, after an hour? Does it improve?
Right.
They'll say, oh, it just takes the edge off. I've heard that a lot. And they'll say it just takes the edge off.
Because they're getting the sedation from the pain med,
That's
not the relief
they're
from
not.
the nerve pain.
Yeah.
And sometimes that's confusing,
Yes.
especially if they're a polypharmacy
Yes.
person. Then you got to
Yes.
say, okay, well, let me run my drug interactions here.
Yeah.
Because some of these meds can't be given together,
No.
and some have contradictions that they can't be given at all.
Mhm.
They can't be crushed. They can't be, so then you got to make sure,
Because
because sometimes pharmacy will make a mistake
Yeah.
and they'll send it in and you're like, whoop, that's supposed to be liquid.
Yeah.
Okay, read your order,
Right.
know your patient.
Yeah, you have those. That's the other thing. We're looking at pharmacy. You have, with nurses, they're like given narcotics. Well, now narcotics have all these different immediate release, delayed release, sustained release. You've got medication. And if you don't know that, you're going to be doing CPR.
That's right.
You can give them, if you crush something like that and it's immediate release, I mean, you're giving them all of that medicine at one time.
Yeah. Or what if they were on one med and they had a reaction? It got discontinued, but they had to remove that booger from the drawer.
Yeah.
And so then you're going to go get them a pain med.
Yes.
First, when you pull out that card, pop that pill out, there you go again. We just repeat the process. You've made a medication error. It causes a whole bunch of paperwork.
Yes.
But more importantly, the patient is uncomfortable. Here we are again.
Yeah.
And that could have been avoided because it wasn't removed like per protocol. And you didn't double check, triple check your med before you gave it.
And that's just normal. Triple
It
checking
happens.
a drug should be part of your every day. And you're like, yeah, but I got 10 patients and I'm giving them 20 drugs a piece.
Yeah, sorry.
You have to.
Yeah.
I mean, that's why we got computers now that makes it easier. Because the pharmacy
They'll come in a roll with them,
Yeah, that's true.
It's not.
The pharmacy has put those contraindications, like with each medication. Don't give this drug if their heart rate is less than 20.
Yeah.
Don't give this drug if their blood pressure is less than less than or equal to 100/50.
Yeah.
Of course, nursing judgment comes into play with those too. Like you said, what if they have chronic pain? They've been living with chronic pain. They're on pain management, and then they're not getting any pain relief. Well, they've been on pain management for years, and now they're in the hospital for acute pain, not chronic. This is something brand new from their chronic.
Yeah.
And they're taking their old medication their medicine they take for their chronic pain. And then acutely, we're giving them something else. And they're like, yeah, but that's not helping my pain. Well, this is where with that type of patient, you really have to know, the history. Because you may be giving them Percocet, but they've been on long-term MS Contin.
Yeah.
Slow release morphine, right?
Yeah.
I'm giving them Percocet.
Yeah.
So they may not get relief from the acute or from chronic because of tolerance, right?
Right.
They've built up a tolerance to narcotics. So within, you're going to be calling the doctor and saying their pain's not relief. We're doing this, this, and this. Their pain's not relief. But the other part of that is you still have to look at what's their vital signs. Am I going to give them this pill? The doctor ordered me to give it to it, right?
But is it safe to give it to them?
But if I give it to them, am I going to be giving them Narcan later?
Right.
So, it's that fine line because even chronic pain management patients, their vital signs don't always react to pain.
Yeah. Heart rate may be 70, but they're over here diaphoretic, sweating, and you're just like, something ain't driving here.
Blood pressure is 110/70.
Yeah. But look at your patient.
But yes, assess the other signs of pain.
Yeah.
Grimacing.
Yeah.
Moaning.
Yeah.
Diaphoresis. They're crying. Yeah.
Guarding,
soaking wet. Absolutely.
Now you're going to pick up on the ones that go the extra mile, the actresses that want to be drug seekers. Please do not assume that everybody's a drug seeker.
No.
That is not your job.
No.
That is outside of your scope. Your scope is to assess this patient and treat them. And if you have any questions about over sedation, under medication, then we're going to have you a communication sheet that you're going to have everything together with before you call that doc with your vital signs and your heart rate and your medications and what labs they have and et cetera, so that you can make an informed and knowledgeable phone call, and that doctor can make a decision based on what you have provided him.
Absolutely.
Or that nurse practitioner.
Yeah.
And
if I give that medicine, if the doctor says you need to give them this medicine, yes, you've given me their vital signs and the assessment, everything I need, give them this medicine. If I give them that medicine, I'm going to be in there every 15 minutes, or I might just sit in there a while.
yeah,
I might pretend they're getting blood. I just started blood on. I'm going to check their vital signs every 15 minutes. Just leave the
cuff on there.
Yes, just leave it on
Put
there.
that pulse ox on their finger. That's a quick check.
There you go.
Yeah.
I mean, sometimes
you just get that stomach feeling.
you do not have a routine, okay?
Yeah. There's exceptions to every rule. Every rule.
Mhm.
And be aware of your policy. If you don't have hold parameters, but you decide you're going to hold that medication, you need an order for that.
You do. That's not. That's
You
outside
can't-
your scope too.
Yeah, you can't just
That
decide.
would become med error by omission.
Yeah.
If you got an order for it, it's not. But if you decide, you're not the pharmacist and you're not the doctor, you can't decide to hold a medication.
Yeah.
You have to, if there's something, their blood, the blood sugar is it's 60. Well, you don't want to give the regular insulin,
Yeah.
the rapid, rapid,
Acting.
the rapid acting insulin. If you feel
But you're going to have a protocol, most likely.
you have a
You
protocol,
have a protocol, standing orders.
if you don't have a protocol, you still call him.
That's right.
That's your protocol.
That's right.
You call him
Blood sugar is this, and this.
because you can't make those decisions.
Yes. Or, they're puking their butt out,
Mhm.
puking their guts
Yeah.
out, and things are coming out all the holes, and
Yep.
you're like, oh, this ain't good.
No.
But we don't have anything to control those symptoms that's preventing me from giving the meds. Call that nurse practitioner.
Yeah. Do not
So
let
you have a
them.
standing order in your
Right.
facility for nausea, vomiting, puking, but you're still going to have to notify, and it's a change of condition.
It is.
Hey, so-and-so's family member, this is so-and-so. Just want to let you know, Mr. So-and-so is not feeling great today. He's already
Mhm.
upchucked twice.
Yeah.
Just want you to be aware. I'll let you know if anything changes.
It could be a side effect from any medication.
Might be a stomach bug.
It could be a stomach bug. It could, yeah. I mean,
It could be all
well,
kinds
they're
of
in the
things.
hospital. They're in the hospital for this, but now they're throwing up. It doesn't matter.
Yeah, they
You
had
have to treat the
anesthesia.
patient.
Do they have bowel sounds?
Right.
Part
There you
of
go.
your assessment. Oh, maybe the bowels are too slow. Now we're not getting things through. Things are backing up this way.
Right. What does that emesis look like?
That's right.
Does it look like coffee grounds? Does it smell like a bowel movement? Okay, there you
There
go.
you go. Are they impacted?
That's it.
We have all these nursing tools in our toolbox.
You
All
gotta
these
use them.
assessment things that we know that we're learning, that you're going to learn as you progress with your skill set.
Yeah.
But the basics, coming back around to the basics, that's your foundation,
That is your assessment.
right?
If a condition changes, I already did my 12 hours. No. If a condition changes, you go back in and you do a head to toe assessment of that patient again because their condition has changed.
Yeah.
Okay. They have new symptoms.
Yeah.
So you got to relook at everything.
Yeah.
Don't call the doctor and just say, oh, they're throwing up and,
Yeah.
have diarrhea. Head to toe.
Head to toe.
You tell them everything that's changed since that first assessment
Yeah.
earlier in the day.
Yeah. Yeah. Because he will not be happy if you say, well, hold on a minute. Let me run back to the room and see.
Mhm.
Oh, no, that's not going to happen.
You don't do that.
We don't do that. We don't do that.
You have everything he could possibly ask right in front
Right
of
in
you when
front.
you call in.
Yeah.
Even if you're in the patient's room,
Yeah.
just call from the patient's room and you have your Cardex or you have your bed profile, you have your notes,
Stethoscope.
everything. Yeah, everything right there, you know?
Yeah.
So if he asks, you got the vital signs,
Yeah.
what is his O2 sat right now?
Right now. Yeah.
It's,
What is their preferred hospital?
that's
Because
it.
see, Yeah. Oh, I want to send them to, oh, but doc, they only want to go to this
What if
hospital.
you got to transfer them out?
That's
too?
right,
Mhm.
right. So, we talked about that, making a quick transfer or a quick doc, we call them SBARs.
Yeah, as far as.
SBAR, form.
Yeah.
Until you get really good at it. And as you're learning, as you have multiple patients, because let me tell you what, you got 20 patients on long-term care, 40 patients on long-term
That's
care.
it. Mhm.
If you don't know them left and right, they start looking and they start getting mixed up. So you don't want to go off memory.
No.
Right? You want to have your P's and Q's. God forbid you give them the wrong allergy or wrong information.
Yeah.
And then here we are, we're in trouble.
That happens.
And it happens.
You know.
People get excited. Things are going downhill. They get in a hurry. They pull the wrong chart up. They'll make a phone call. It may be the same doc because, you got a medical record of the whole facility.
Yeah.
And then you start, and then you have to call them back. Oh,
Yeah.
I did an oops.
Well, and a lot of times, the doctor will order something, and if you did not tell him that this patient's allergies are this, this, and this, or I've had it where they say, hey, give them some Tylenol, and then immediately I see, they can't have Tylenol, they have some liver insufficiency or failure
Transplant or whatever.
Yeah. So, it's that kind of thing. I hope you catch it if they don't catch it.
That's right.
I mean, same thing for you. You kind of also become a fact checker with the doctors, with the pharmacy, the dietitian, with the nurse practitioner.
The social worker, as they get ready for discharge.
That's true.
Hey, did you remember that they don't have elevated seat, that they're going to need a hospital bed?
That's
but
true.
The room ain't big enough, so
Yeah.
somebody's going to have to help them move around the living room furniture.
Because as a nurse, you're discharging that patient. Well, see, now they do have computers discharging. They have computers discharging patients now.
No.
A person comes on the screen.
Okay.
But it's like a Skype discharge.
Yeah.
They just roll the machine in there and turn it on.
So we use that for translation for my workers' comp.
Okay.
You wheel in the translator.
Well, that's great.
Oh, it's fantastic. And and then they transcribe everything for you, give you what they
But
say.
I've even had a discharge like that.
I've never seen that.
But the thing about it is, as you discharging, that's true. Even the home, the supplies that are going home, any equipment, like you say, well, the toilet seat's not here yet. I can't discharge them until they get that.
Yeah.
Or if they've told me the equipment's going to be delivered to their home, you got to know that because how we always did it, you had to know if it had to be in their room before you discharged them. Because a lot of times they need that equipment to get from the room to the car, from the car to the home. You know what I mean?
Yeah, absolutely.
They couldn't go to the restroom until they had that toilet seat set up, the high toilet seat or whatever it was. You know?
Right.
So stuff like that, you're thinking, that's my job as a nurse too. It absolutely is. You are the fact checker for everything as you discharge them.
It's
They have to have
comprehensive.
everything. Even their doctors, I had to make doctor's appointments before they were discharged.
Well, home
Okay,
health.
your next appointment is this. Yes, home health is
will be
supposed
there
to
at 8
call
a.m.
you.
in the morning
Yes. Mhm.
to do their intake.
And here's the number if they don't show up.
Yeah.
So it's kind of like you had, it's that I'm every woman thing again. I'm every nurse.
Yeah.
You have to do everything.
But having all that and going through all that, I'm not so sure about the computer thing because I would want somebody to say, we've gone over this, we've gone over that.
Right. And here it
is.
is exactly what we just went over.
Yeah.
And I need your signature to say that
That
I
we've
did
gone.
go over this with you.
Yeah.
And you have a copy of the information.
Yeah. And this star down here, this is who you're going to call if you have any problems.
That's it. Mm-hmm.
And that gives them reassurance, like, okay, I'm not just out here trying to figure it out on my own.
Yeah.
Or they get home and they're like, I don't have the thing, and the home health said
I'm going to have to go to
my
the
insurance
ER.
ain't going to. That's what they're going to do. They're going to get right back in the system, and hopefully they still have Medicare days or whatever that got them out of the system.
That's true.
The benefits. They're going to get right back into the ER. They're going to go through the system. They're going to get depressed again because they failed. They think they failed. The family, something has happened.
Yeah.
And here we go again.
But isn't that managed care where they make sure if something happens, okay, if this happens, you call this number, don't go to the ER.
It's supposed
If
to
this
be.
happens, call this number, don't go to the ER.
Supposed to be
Because a lot of times the goal for managed care is to keep them out of the hospital.
and readmissions.
Readmissions.
Right.
Absolutely.
But where they're referring them to, are they open on the weekends for these Friday discharges at
It
7
always
o'clock?
happens on
You
Friday.
see,
It always happens on
so
Friday night.
we're discharging from the facility on a Friday night.
Yeah. Yeah.
Nobody or nothing is going to show up there until Monday.
Mhm.
Sometimes, and Mondays are terrible because nothing has happened over the weekend.
That's it.
So it may really.
And they're on
Tuesday.
catch up on Monday.
Yeah, and by then they're back in the ER.
See, that's the thing with managed care. They, at any given time, if they have a problem, they should have, instead of an ER, they should have like a doctor's office that is available 24/7. Would that not work?
Like a post-discharge follow-up.
I don't know if they could call it anything but an ER. If they could call it a clinic.
Right. Interface
Yeah,
between the two.
a triage
A
clinic.
triage clinic.
Yeah.
Post-discharge, pre-admission clinic.
Yeah, we can have a big long name or initial,
We'll
Yeah.
put another acronym for it.
Yeah, triage clinic for
Post-
managed care patients who we're trying to keep out.
You're trying to stay out of the hospital and
Yeah.
your doctor doesn't work weekends.
That's right. That's right. So, I mean,
There's a need.
There's a
And
need.
if you're at a facility, and I had talked to one of the facilities I worked with before, we used to have education with that family before they were ever discharged.
right.
That doesn't happen much anymore.
Yeah, we always did that too.
Right. But once they are discharged, do you have somebody that's going to call them?
A
We
navigator.
wanted to create that position. I wanted to create that position. Of course, it wasn't financially feasible.
That's always the explanation.
It's but how many readmissions we could have
We
tracked
could-
that
Yes.
and come up with some numbers had they played out my plan.
Right.
Right.
Did I call and make sure they had their equipment? And does it work for you?
Yeah.
Is something too small? Is
Right.
something too large?
Yeah.
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 Or is it broke?
Yeah.
Did you get it broke? Was it not put together? And
You didn't
can't
get the
it
charging
together?
cable. Okay. Let me get a charging cable.
That's it.
You
Yeah.
know, you need wound care supplies until the health care gets there. Okay. We could have the Walgreens deliver that to your,
That's it.
right? You have all these community resources.
Do they still have navigators like that? I think they have
Some
some
facilities do.
post-surgery,
Yeah.
but not everything.
Mm-mm.
Not post everything. Maybe just post a specific thing like surgery.
Yeah. See, and you would think it would be a system if we're trying to keep people healthy and from using acute services that we really should not use sometimes that way. There should be a way to manage that,
It's like managing their care post post surgery or
change of condition.
change of condition of any
Change of
kind.
condition
Right.
triage.
Right. That's it. Yeah. There you go.
Triage and follow-up. I don't know.
CO.
Yeah. Let's see.
COC.
Condition.
F.
Yeah.
S or whatever.
Yeah. Yeah, we could do FU.
Okay. Can't ever do it.
Can't do that one. Change of
Illegal.
condition, something.
Yeah.
But we could start by more facilities having that post-discharge coordinator following up and making everybody that discharged, even in the past week,
Yeah.
call them folks.
Well,
Check in.
And I hate to draw attention again to that certain age population, but they're more likely to have something change.
Yeah.
I mean, based specifically on just age-related issues,
Yeah.
I mean, we have every system we have ages, and I mean, you can have normal aged symptoms, but at 85, you may naturally have COPD
Mm-hmm.
or an enlarged heart, right?
Right.
Or so
Well, you don't even have to be 85. What do you have?
no,
These genetics.
you can do it at 65.
Right.
Yeah, genetically.
Genetic predisposition
Mhm.
on a lot of things.
Yeah.
The way we lived our life as younger folks, and Sometimes it's the mileage and not the years.
It's the mileage,
You know,
for almost everybody.
Because I've got a couple 85-year-old folks that I'm trying to keep up with.
Oh, me too.
You know,
I have a dad and a stepdad that are 83 and 85, and they keep me hopping.
yeah. My little workers' comp lady that I fell in love with, she's going to be 79 Saturday, tomorrow. 79 and still kicking it, driving and maintaining our home, cooks dinner for smart as a whip.
Oh, yeah.
Fries, you know.
My stepdad manages everything. He lives by himself in a huge home and does his lawn care and plants things.
Yeah.
And I mean, he goes and plays golf 5 days a week sometimes.
Yeah.
I mean, I'm amazed.
Yeah. So there again, we need to individualize.
Not that he don't have problems.
Right.
He just rises above and says, I'm not going to let this keep me from doing what I want to do.
Right. And he has the resources
Yeah, absolutely.
and
Yeah.
the support.
Yeah.
I mean, you know,
Yeah.
what better
If he
family
has a
members to have
problem,
as nurses?
He calls me. See? I take him to his doctor appointments. Yeah.
And you know the questions to ask, and
I do.
right. So if you don't have a nurse in the family, or you're a new nurse and you want that extra support, these are things that we're talking about. When you go in with your loved ones to the visit, be prepared. Have your little notebook and have the questions that you already had. Have your medication list, right? Anything that's happened, vaccinations, all those things.
Yeah.
To be prepared so that you come out making informed decisions and know that your loved one is well taken care of. If you don't agree with the plan of care, if you don't think that this is right, get a second opinion.
Question.
Talk to somebody else.
Absolutely.
You know, because not every doctor is for everybody, and not every patient is for every doctor.
Oh my goodness.
And we're all individual too, and you have to find the right fit to make that relationship work and to be able to communicate with them. Otherwise, you're going to sit there and just get the bare minimum. They're going to give you the bare minimum, and you ain't going to be happy, and your body ain't going to be happy.
Well, and that's it. You got to communicate with your family member.
Yeah.
Because sometimes they don't tell you nothing either. And you get to the doctor and nothing's accomplished because you don't know that they've been having tingling or burning, with their feet.
Yeah.
So, you've got to communicate with your family member, your loved one, your patient. Then when you are with the doctor, that's when you need to know all this to discuss. Because, sometimes when, the patients or the family members get with the doctor, they go blank.
Yeah.
And not a lot of people are people who will write down questions and take with them.
Yeah.
Some are, but for the most part, no.
They don't. Yeah, they don't. They're not.
They will just go and not ask any questions and not write nothing down before they will write something down.
Yeah.
I don't know why. It just happens that way.
But that relationship and you being aware of what's going on in their life, you can say, but Mom, what about that time that you were telling me that you got really dizzy? Like every time you stand up, you get really dizzy.
That's right.
Oh yeah, I forgot about that.
And remember, you quit taking that medicine without the doctor telling you. Because you didn't think you needed it.
That's right. So
that's not how we do things.
Do we really need to, can we look at her meds again? Because she's thinking she may not need everything now.
Yes.
Because coming from them,
I know,
is totally different than coming from a family member, from, the doc. That's
true.
That's a different relationship.
And you have to listen to what they're saying, just like you're listening, as a nurse, you're listening to your patients.
Yeah.
Your family, you have to listen.
Yeah.
Because my dad will say, that has a lot of side effects. And I'm like, quit looking up Dr. Google. Well, I don't need to take that medicine because it's got side effects. I just quit taking it.
Yeah.
No.
And sometimes stopping a medication is worse.
Absolutely.
Then, some things have to be tapered down. You can't just stop.
They can cause some very bad side effects if you just suddenly stop a lot of medications.
Yeah.
And then again, you have some medications that are ordered to be taken together.
Yeah.
So if you stop taking one of them, you're not getting the full benefit of
Yeah.
what those two medications
Yeah,
together
they
are
enhance
doing.
each other.
Yes.
Yeah.
Potentiate, yes.
But is that something maybe that was lost in the communication when either you were at the pharmacy or at the doctor and said, I need you to be sure that we take these together,
Absolutely.
or did they just say, here's 2 prescriptions,
That's it.
with refills,
Right.
see me in 6 months.
Right. We're not
So-
educating
Yeah,
healthcare. I'm not seeing a lot of education,
yeah.
Even as I'm starting to go through the system a little bit, I'm critiquing,
Yeah, of course.
well, they didn't tell me to do this, or they didn't do this, and they didn't give me any education. And
Yeah.
I mean,
Oh, yeah.
I'm too critical.
Your worst patient is going to be a nurse that doesn't tell you she's a nurse because
Because she's evaluating everything that's going on.
Yeah.
Yeah.
And there's a certain way to, sometimes you got to say, look, I'm in the healthcare field too,
Mhm.
and what you're doing, I'm not comfortable with.
Absolutely.
And it needs to be in a non-threatening way because that is a ripple effect a lot of times.
Right.
But you need to communicate that, and we don't do things that we knowingly
Yeah.
know are not correct, right? Whether that's the doc saying it or you have to be able to.
Mhm.
I'm not sure I agree with that. Can we talk about that a little bit more?
When you're the patient, it's hard too.
Yeah.
When you're the patient, nurse, you're the nurse, but you're the patient. It's hard to come across nice.
Yeah.
I'm sorry, it is.
It
Because there's a reason you're a patient instead of a nurse right now.
Yeah.
Something's going on, you're in pain, or you've had surgery, something.
Yeah.
It's hard to be patient at that point.
Yeah.
Or kind, or, okay, how do I say this, right?
Right. That's my biggest struggle because if it doesn't come out of here, this space is going to give it away.
My face will give it away.
And sometimes folks will look at me, and that's all it takes is the look.
It's
and they're
the
like,
look.
Is there something that?
Yeah.
Yes, there is. Like
People read my face more than anything.
one thing that we did want to mention before we wrap up this session is on October 25th is Prescription Drug Take Back Day, and we know that medications in the home is a risk, whether you have kids there or other people come over and they go in your bathroom and open your cabinet and see what you have. If you aren't using it, if it isn't prescribed, if it's expired, please find out in your community where you can take those drugs and they're properly disposed of. It's not recommended to put them down the drain or any of that stuff. We don't flush them in the toilets because that gets into our water systems and such.
Yeah.
So check with your local fire department, your hospitals, I'm sure pharmacies, and get medications out of the house that could get confused with something else. Maybe you don't take that particular strength anymore, right? So you don't want to get confused over what you're supposed to be taking. If they've expired, then their bioavailability and everything has changed.
It is.
And it's not safe anymore to take it.
Yeah.
So get rid of that stuff. Check your dates on your EpiPens. Check your insulin, vials. Do you need to get a new prescription because you don't use it as much?
Well, and pretty much EpiPens, you are to giving you one every year anyway.
Right.
But, I think people, when they don't use them, I don't know if they actually
renew them.
Yeah, I don't.
Yeah, they're very expensive.
They are.
They're very expensive. Narcan, same thing.
Yeah.
If you have somebody at home that's on medications, maybe they're a COPD or they've got obstructive sleep apnea, you need to have a Narcan, right?
Yeah.
So find out. A lot of times those are free at community centers. So keep one of those. Learn how to use it. Talk to your doc about it. Of course, you'll need a script or whatever, but we want to make sure that we aren't putting folks. We want to make sure that you have the tools that you need in the event that something like that does happen. Maybe they're on pain medicine and they decide they're going to have some wine with it, and not even thinking, I'm on this medicine every day. We've had some wine, we've been out to dinner, we've had family over, friends over, and all of a sudden they're very lethargic and okay. So we need to have an action plan.
It's a shame they don't just automatically give one of those NARC kits with anytime they dispense those type of narcotics,
Especially if they're in pain management, I would think
Yeah,
that should be part of their protocol.
yeah,
But I'm finding that it's not.
really.
I have started asking my pain management docs for the script, and they're very receptive to that. So just another thing with communication. Hey, doc, I noticed, this
Yeah.
person is on, when we reconcile their meds, they're on this, and we don't have a script for Narcan. Do you think it'd be okay?
That's right.
If we, just in case we need that.
Mhm.
And then we're going to teach them, when to use and how to use and all the follow
If
up.
there's family members, whoever's with them the most.
Yeah.
Absolutely.
Yeah. So don't forget the end of the month of October, if you can get your drugs out of the house that you aren't using, decrease that risk of errors and people getting it that don't need it. Somebody breaking your house, take everything you got.
Mhm.
We don't want those things to happen.
I have a story with the expired medication. My daughter being that new pharmacist, okay?
Mm-hmm.
So, just cleaning out the medicine cabinet. She had a little medicine cabinet in the bathroom, just cleaning stuff out. And I'm like, this is a full bottle of Benadryl.
Mm-hmm.
25 milligrams over the counter, right?
Yeah.
Big bottle. I think we might have got it at, one of the,
Warehouse stores.
yeah, one of those. And oh my gosh, it was probably 500 tablets. And it was open, but I don't think we took 3 out of it.
Yeah.
Or it might not even been open. And I'm like, it's Benadryl. You never know when you need a Benadryl to have a reaction. We might as well just keep that. And if we need it, we can take it. My daughter, Mom, that is an expired medication. It will not react the same way if it's like, come on.
Yeah.
This is Benadryl.
Yeah.
It's supposed to stop any reaction, whether it's a year old or not, or whatever. Of course, I went through medication cabinets and it been 5 years old.
Oh, yeah.
I mean, Tylenol, over the counter, ibuprofen, stuff like that. Never.
Big A.
Never. Oh,
Yeah.
Oh my gosh.
Yeah. But they all have expiration dates.
They all have expiration dates. And yes, they say that the composition can change and they may not react the same way. So yes, if you have a reaction to something and start itching and you need some Benadryl, it may not react the same
Right.
way.
You have to take 6 and 6.
That's right.
We don't.
Yeah, I know. Like, okay.
Yeah. We don't want to promote that, but it's just err on the safe side.
Always.
And,
Always. But yeah,
buy a smaller container of Benadryl next time. So
Right.
Yeah.
I had a big thing. I had a liquid. I'm like,
Yeah. What happened that we had all the
I do
Benadryl?
this. Yeah, I don't know.
And now it's old and
now it's old, and I mean, what do you do with those? Just throw the whole thing in the garbage, or Benadryl? Would you take it somewhere? Or
no, I wouldn't take it somewhere.
just throw it in the
I
garbage?
would throw it in the garbage. Yeah. Now they said, I read a thing the other day actually, that you can, how you have your coffee grounds or whatever in your container, you can throw them in that so people can't fish things out of your garbage.
Kitty litter.
Kitty litter, same
I've seen
thing.
that.
Yeah.
I've seen them have a little gallon bag of a little bit of kitty litter in the bottom. They put some water in there, and then they throw the medications in there.
Yeah, and it'll clump it up.
Yeah.
Where
They'll
people
dissolve and clump.
Yeah. So nobody's going to take that out of
They're
our
not going to dig it out.
So that's definitely an option, I guess, for all meds. If you don't find somewhere, if you're out far or you're like, I'm not going to make it down there and do that, I'm not going to remember it. Get you some kitty litter and
That's it.
throw it in there. And
I've seen hospice do the kitty litter. What was the other thing you said?
the coffee grounds.
Coffee grounds. I've seen both of that. Yeah,
Yeah.
I've seen them do both. Hospice with. Yeah, I saw hospice. Yeah, with my daughter, and then with my mom, they did kitty litter.
Yeah.
Like, I mean, the nurse was doing it. I'm like, y'all.
There again, adaptations.
Yeah.
Right.
Home health nurse. I mean, a hospice nurse, Can you imagine kitty litter? I mean,
Well, like the
That's
sharks at
genius.
home, most folks at home don't have little red boxes.
Right.
We're going to get a bleach bottle.
That's
We're going
right.
to mark needles on there
Yeah.
and keep it closed, and
Yeah.
that's how they're going to
It's
be.
a nice thick plastic
It's not going to function.
jug. Yeah,
Yeah.
that's true.
Yeah. So the home.
You got to adapt to the environment you're practicing health in,
Yeah.
you know,
Yeah.
as a nurse, as a family, as a caregiver, you know.
Yeah.
But thank goodness we learn all of that.
That's right.
You know?
That's right. That's right. So when y'all's Pixis goes down with all the electronic stuff in it, your Cardex and all your Cubex and all that, you know, as folks that can adapt, we know how to do the paper. And
That's what we always said as a nurse. I'm adaptable and I'm flexible.
Uh-huh.
I can adapt to any situation and be flexible to go to a different floor, a different unit.
yeah,
In the middle of my patients, all of a sudden now they're going to send you to another unit.
yeah,
You have to be adaptable and flexible.
you're there for them. You
That's
know,
it.
That's it. And wherever you're needed.
It's not what makes you happy. It's what care is needed and has to be provided. So,
And you know, maybe that's some kind of intervention, and you're the one person that's going to connect with that patient,
that's true.
and they're going to remember you forever, and it all works out fine.
That's
So,
true. Mhm.
anything else before we close up for October and we're talking about?
Of course, October is National Breast Cancer Awareness Month. So, you know, everyone knows that. Wear your pink. Unfortunately, breast cancer is one of those things that has pretty much touched every family.
Yeah.
I know that better than anyone because of my daughter and my mom. I've had breast cancer, so that's just always we always look at and be aware of Breast Cancer Awareness Month. It's a big celebrated, organization, American Cancer Society. Locally, we have. Am I supposed to say
You can.
Mary Ellen
Yeah,
Locher?
that's a
The facility over there at CHI, the Mary Ellen Locher Breast Cancer Center, which is amazing.
yeah.
There is not a service they don't provide for, reconstructive surgery. They do tattooing. They do, they have ladies who knit the hats.
Yeah.
They knit like the little vest so that when you leave after a mastectomy, you've got a little vest that has the pockets that holds the drains.
Yeah.
And until you go home and you got that. So it's amazing that they drop off blankets because sometimes with the chemo and everything, they get cold.
Yeah.
I've seen them do, you just see so much. I wish with a lot of the different things that we were as proactive.
Well, they have the mobile.
That's true.
Scans. They have that big bus that comes out.
That's true. Mobile mammograms.
Yeah.
Absolutely. They make it accessible.
Yeah. And you don't have to, if you don't have the pay or you don't have the insurance, they've got a form. They'll take care of that.
They will.
You.
You can get it free.
Fantastic.
Mm-hmm.
Just absolutely fantastic.
Yeah. So remember that. And yes, let October be the month you get a mammogram.
Yeah. Even if you're not, what is the 40? Is that what
40 and older now for mammograms. Yeah.
But if you have family history, if you have, you come up, you've done a breast exam, your child has done a breast exam, something just doesn't feel right.
Yep.
Cancer isn't age specific.
It's not.
We're going to wait till we're 40 to jump into your boob. That's not how things happen.
No.
And sometimes, had we gotten earlier diagnostics, then we can catch things earlier.
Absolutely.
Or if nothing's going on, that's great. We've got a baseline. We'll come back next year. Well, now we have something to compare to.
Right. And that's the good thing about that type of thing is, if you're genetically predisposed to breast cancer or any kind of colon cancer, any kind of cancer, the thing about it is they will put you as a patient in a group that makes you high risk. So therefore, you're doing more diagnostic and clinical
Preventive things.
assessments. I go twice a year for the actual breast exams
Yeah.
with the doctor. And then I have a MRI of the breast once a year and a mammogram once a year,
Yeah.
6 months difference,
Separate.
So we're keeping a very close watch on it. So, and that's what the mammogram is what found, my breast cancer, which it was stage 0.
Yeah.
I mean, it was just brand new cells, contained within the duct,
Yeah.
but thank goodness.
Yeah. Early
Mammogram.
Right. Well, good skip that year.
Exactly. What if I just said, I'm not going to do
It's been good for a couple of years, and
Right.
we're going to go ahead and wait till
Then
next
it
year.
would have been a whole lot more.
That's right.
It would have been a mastectomy and chemo, and
Or maybe what if it had metastasized?
that's it.
We don't know,
That's it.
because all cancers are
Completely
different,
yes.
and they act different and
They
have
do.
different properties, and so definitely mammograms are so very self-exams are so important. You got to know your body.
Yeah.
You know, you're taking care of a patient and you notice their nipple is inverted, or
Right.
you're seeing
Discharge from a nipple.
crazy looking bumps on their skin that
Dangling. Yeah.
doesn't look right. Okay, then we need to talk to that doctor because they're going to need an exam.
That is not normal
Yeah.
for any woman.
Yeah.
I know women, have inverted nipples sometimes just naturally with, have issues with breastfeeding, but if you have one breast that's inverted and one that's not normal.
Yeah. Yeah.
Because, and it just happened recently, so definitely it's not.
That's right.
Kind of thing.
That's right. Yeah.
But just be aware of October as physical therapy month, pharmacy month, breast cancer awareness, Down syndrome, and SIDS awareness.
Yeah, absolutely.
So,
Absolutely. A lot going on. Thank you, everybody, again, for dropping in. I hope you learned something. We look forward to speaking with you, teaching you more things, and sharing our bits of wit and wisdom. We call them doses. Ain't that what it is? Doses of wit and wisdom.
Yeah.
Yeah, absolutely. Thank you so much. We look forward to seeing you again.
Please like and follow.
Oh, yeah, and share.
That's good. Thank you. See y'all.
Don't forget Shaq.
This podcast is for general informational purposes only and does not constitute the practice of medicine, nursing, or other healthcare services, including the giving of medical advice, and no doctor/patient relationship is formed. The content of this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice for any medical condition they may have, and should seek the assistance of their healthcare professionals for any such conditions.